All right, so that's bronchodilators, one of the things that we can do. Other things that we can accomplish would be to alter the respiratory tract fluids. And why would we want to do that? Okay, it depends. A lot of diseases, particularly the infectious ones, you get a very thick, tenacious mucus secretion. And that is hard to get rid of, to normally expectorate, or expectorate means to move out of the lung and cough up. So you want a nice thin watery fluid to do that. So we want to decrease those respiratory secretion viscosity. Surfactant production can be a problem in newborns, particularly premature newborns. So we can address that. And lastly, foam in severe pulmonary edema. These lungs are so wet and they're working so hard, this rapid panting respiration, they actually create foam in the airway passages that mechanically interfere with ventilation, and we can do something to decrease that foam formation. All right, so let's talk about altering the respiratory tract fluids. So you'll recall in the lung there are two primary secretory cells. You've got goblet cells that produce mucus, and they're stimulated by noxious materials, including infectious processes. Okay. Then we have the tubulo-acinar glands that are under parasympathetic control, and they primarily make a thin, watery secretion. All right. So from this standpoint, when you have thick, tenacious mucus that you can't cough up, you want a thin, watery secretion. You don't want a thin mucus or thick mucus secretion. So what can we do to change that? We can add moisture directly. We can stimulate the tubulo-acinar gland, so we switch to that thin, watery secretion instead of the mucus. Or if the mucus is already there, we can chemically cleave it at its disulfide bonds to make it thinner. All right, adding moisture actually is probably the best thing to do. It's the simplest, and it's not as elegant as, say, using an expectorant, but it's probably the thing that works best. All right, now we can do this with steam. So you can get a steam vaporizer and put it in the area with the animal. That's less convenient in a hospitalized situation because it steams up the whole room typically. But certainly owners can do it at home. And a lot of people will say, put them in the bathroom and turn the hot water running in the shower and let it steam the room. That's a terrible waste of water, but it works. More commonly, what we do in hospital situations, we nebulize saline. Not water. Water is irritating to the respiratory passages. We want to use isotonic saline, and we break it up into a fine mist. And I've added this part to make a point. You can get different types of nebulizers. You want to make sure it produces a fine droplet size. All right. The most mists wind up depositing in the back of the throat and the upper trachea airway. Only really small particles make it to the deeper respiratory tract. So we want a very small diameter particle if we want to get down into a pneumonia, down into the alveolus. That's the goal, is to have a particle less than 5 microns. And what that means is that ultrasonic nebulizers have an advantage in that regard. Ultrasonic nebulizers will get that very fine mist that will go deep into the lung. So you'll see those used a lot. I tried to use them when I was in charge of ICU. They worked, but the problem was students kept dropping them and they'd have problems, and we couldn't keep them working. We use what's called a jet nebulizer now, which is a mixture of droplet sizes, but most are small enough to reach deeper. Not as well as the ultrasonic, but it's kind of a compromise. Okay. So this is very effective, and you'll see this done a lot on bronchitis and pneumonia patients. Okay. We'll nebulize them multiple times a day in the cage. Don't forget to keep them hydrated. In fact, just a little mild fluid diuresis is actually quite effective. So when you have a cold and they tell you to drink lots of water, there's a good reason for that. It actually helps break up the secretions. So all these are good. Now up here I'll just mention, this is a controversial thing about using oxygen therapy. If you have an air compressor at home or have worked with these, you'll know that on the bottom there's a little spigot valve that you turn, and that's to drain condensate out of the tank. And any gas under pressure will condense the water vapor in that gas into a liquid, and so the gas becomes very dry. So when we're using compressed oxygen, it's a very dry gas, and that can dry out the respiratory secretion somewhat. So it's very common when we use oxygen that we run it through a bubbler. And that is just a container that's got water in it, and the tube goes down into the bottom and fine bubbles go out, and the idea is that you're adding moisture back to that oxygen where it doesn't dry out the respiratory tract. The reason it's being questioned is when they've looked at it, at room temperature, it's hard to really get a lot of added moisture back with these things. So I would say the majority of time we do try to humidify, we do bubble the oxygen, but there are people that don't do it on this basis. So any way you look at it though, adding humidity, moisture directly is probably one of our best ways to break up these thick secretions. Yes? Do we ever worry about fungal spores in the nebulizer? Surprisingly not, if you're just regular cleaning and drying is the key thing. If you keep this constantly filled with water and just move from one to the other, yes, you're going to have contaminants, either fungal or bacteria. But every time we finish one of these things, we empty it completely and we dry it before the next time. Otherwise, yes, it would be a concern. Surprisingly, we have few problems though if we do that. All right. Now the fancy way to do this pharmacologically is to give what's called an expectorant. And an expectorant is something that thins the secretions so they're more easily removed by the mucociliary apparatus and more easily coughed up. All right. Just a note, we don't want to use cholinergic drugs. Those work, all right. So we could use bethanechol or pilocarpine, but they have too many side effects, so we don't do that. All right. We have three that are used. We have guaifenesin, the saline expectorants, and the volatile oils. All right. Guaifenesin, also known as glyceryl guacylate, you know, as Mucinex in the dirty team mucus down here. All right, the big glob. All right. This is in a ton of over-the-counter medicines, and you can buy that. I hate to break this to you, but it doesn't work. All right. Here's the usual dose in humans. All right. There are no studies to document that it has an expectorant effect in humans. You say, well, how is this on the market? The reason is that guaifenesin was an old drug that was grandfathered in without any required safety and efficacy testing. So when the company making Mucinex came along, they did not have to show safety or efficacy. They had to show that their blood levels were similar to the old product. And by showing their blood levels were similar, they got it approved. So there is no data to support Mucinex works. Okay. In fact, when we've looked at the dog, here you see the human dose at 50 mg per kg. There was no effect on respiratory secretions. In the rat, they finally got it up to twice the secretory rate, but it was at 250 milligrams per kilogram. and it took 1,000 milligrams per kilogram to move it in the cat. So guaifenesin, in my mind, is a waste of time and money. All right. And you will still have physicians put you on guaifenesin. It's one of my pet peeves because it's still out there as a dogma. All right. Now another group are the saline expectorants. These are various salts. They work indirectly, and actually this is how guaifenesin is supposed to work. These both supposedly work by irritating the GI tract that reflexively stimulates the vagal nerve parasympathetic activity, and that stimulates the tubulo-acinar glands. That's how these are supposed to work, okay? So the drug is irritating the GI tract, that irritates or stimulates the vagal nerve, that increases parasympathetic tone, that stimulates the tubulo-acinar gland and thinner secretions. All right. And these all, again, cause gastric or intestinal irritation. Very little data to say how it works now, how well it works. Now in, for example, iodine toxicity, you will see coughing more frequently, but whether the doses we actually use have an expectorant effect has never really been proven with these. All right. So both these, this is I basically view as not useful. This is circumspect. There is a little bit of evidence that the volatile oils, the volatile oils might work by directly stimulating the tubulo-acinar glands. This would be things like menthol and eucalyptus, okay? The problem is they're not really easily used in veterinary medicine. This is like Vicks Vapor Rub. There were old products, actually these could be injected IM as an oil, and they would be absorbed and volatilized in the lung that way. I haven't seen those in ages. By the way, this is one of the things that I kind of smile about when I think about growing up. My mother, I don't know if you've had this happen to you, but when you were little, you had a cold or congestion, and your mother would rub your chest with Vicks Vapor Rub, and mine would rub it and then put a towel over it. I think she thought it was trapping it down, so it would penetrate through my chest wall into my lung. And really, the only thing that's happening is you're getting vapors going up into the air and you're inhaling them. So all that time you had that greasy chest, you could have just smeared some Vicks Vapor Rub on your upper lip and done the same thing. Okay. So those might work. So obviously I'm not a very big fan of expectorants. Primarily use direct addition of moisture to the respiratory tract. Mucolytics, okay. If you've already got this thick mucus, why not take something that cleaves or breaks down the mucus? And acetylcysteine is approved in humans for this. It chemically cleaves the disulfide bonds and makes a thinner fluid. It's used in humans with cystic fibrosis. They have a gene defect where the mucus is not normal, it's very thick, it's very tenacious, affects their respiratory and their GI tract. This is approved to nebulize. You make a solution and you nebulize it and they breathe it in, and it helps break up those mucus secretions, and then they spend a good bit of time coughing and coupage in the chest trying to get those to expectorate. Okay, rarely used. I don't know that I've ever seen this used. There was a physician, Tim graduated last year I guess, but he was a respiratory physiologist, pulmonologist, there we go. And he said that he really had a lot of patients that didn't tolerate this real well. It was fairly irritating to the respiratory tract, and occasional bronchoconstriction has been reported. So it's a nice idea, but it seems to be that the local irritation may prevent its common use. And certainly it is not very commonly used in veterinary medicine. Interesting idea. Where we do use it has nothing to do with the mucolytic effect. Where we do use it, of course, is as an antidote to acetaminophen poisoning. And all you're doing there is you're providing sulfhydryl groups that the body can then turn into glutathione. All right, increasing surfactant production. Neonatal respiratory distress syndrome is where you have inadequate surfactant in a newborn, or more correctly, a prematurely born animal. Normally what you have is the lung is rocking along in the fetus. There is no surfactant. And you recall that there's a glucocorticoid, a cortisol surge right before parturition, a couple of days before parturition. And that cortisol surge stimulates the type 2 alveolar cells to produce surfactant. And that surfactant in the lung allows the lung to expand easily when they are born. So they can take a first breath and expand that lung. If that surfactant is missing, those airways stay stuck together and you don't get adequate expansion. All right, so it is a problem. The way we deal with this is if we expect a premature birth, all right, and sometimes this is in the scenario where you're inducing a cow or a mare with the expectation that we have to get the foal calf out before the animal dies of some other disease. That's where we most commonly run into it, but occasionally you'll see prematures otherwise. If we give dexamethasone or betamethasone, dexamethasone is what we use in veterinary medicine. In women, they'll give betamethasone. If we can do that at least 36 hours before birth, ideally 48 hours, this crosses the placenta and stimulates those type 2 alveolar cells in the fetus to produce surfactant, and we decrease the incidence of neonatal respiratory distress syndrome significantly if we can do this in advance. If you wind up with a premature animal that already has it, it's much more problematic. Steroids don't really seem to have that much benefit after they're born, giving the newborn steroids. What is done is to give exogenous surfactants. These are available as human products. One is actually harvested in slaughter plants where they wash the respiratory secretions from either pigs or cattle and then purify off the surfactant. Now there's also a recombinant process to make human recombinant surfactant. But these are administered by inhalation to the premature animal/infant to help expand the lung when neonatal respiratory distress syndrome has already occurred. All right. And lastly, the foam I mentioned, this is primarily in severe pulmonary edema where they have a very rapid respiratory rate, and mechanically it's just creating a lot of foam that then interfering, physically obstructing the airway so they don't ventilate properly. We'll certainly suction out anything that we can reach. We don't humidify, we try to avoid that. But a little trick is if you will nebulize dilute ethanol, it will act as a surfactant to break up the bubbles. All right. One of the things, this is just a side note, but it makes the point. If you ever have had to wash out a soap container, you know how long it takes to get rid of the bubbles, the foam. You know, you sit there and you shake it and you dump, and then put more water and you shake it and it foams and you dump. Add a little isopropyl alcohol to it. It cuts the foam just right out. Okay, and that's what you're doing in the lung here. It's acting as a surfactant to break that. Okay. We can change the respiratory pattern. All right, we can give an analeptic, and an analeptic is a respiratory stimulant. It affects the respiratory centers of the brain, and we use it during apnea or depressed respiration. There have been different analeptics. There is only one on the market that has a reasonable safety margin, and that's doxapram, trade name's Dopram. You've probably seen this used. A lot of veterinarians, when they deliver C-sections, they'll put a drop of Dopram under the tongue of the puppy or kitten to stimulate respiration. Some will inject it into the umbilical area, and this works to stimulate respiration. Occasionally, we'll use it with depressed respiration in anesthetic overdoses. We would rather use artificial ventilation, though, in those cases. If you have the ability to breathe for the animal artificially with a ventilator, you're far better off than trying to stimulate respiration with an analeptic. But in those cases where you don't have that capability, as in you're out in the field with a horse or a cow or something like that, then you certainly can use Dopram. But it has a very small therapeutic index. The major risk is seizures. This is stimulating the respiratory centers of the brain, but it's also stimulating the rest of the brain as well. And in fact, you'll actually, if you give it to an anesthetized animal, you will see a partial recovery sometimes in the anesthetic state. They become more awake after giving doxapram than they were before, and that's from the general stimulation. It is possible to cause seizures before you stimulate respiration in some worst case scenarios, so you don't keep giving it ad infinitum. If they don't respond to one, maybe 1.5 doses, then you really need to be looking at artificial ventilation. Yes, question?
Can the stimulatory effects of doxapram be a good thing if you're trying to resuscitate neonates?
Absolutely. Absolutely. If you're trying to resuscitate any anesthetized animal or a neonate, the stimulation effect can be a good thing. Like I say, I have at one time for xylazine reversal, people that didn't have yohimbine or tolazoline or one of the reversal agents would give doxapram to those animals, and they would become much more alert from it. So yes, it does do that. The problem is you can overdo it and cause seizures really easily. Another thing that we can do is we can control the respiratory rate. In this case, we're trying to blunt it with opioids. And this applies to just about any form of dyspnea, okay? It's particularly well documented in humans with pulmonary edema, but most forms of dyspnea will respond. And the idea here is that you've got an animal struggling to breathe. They have air hunger. They can't get enough air. They're fighting, trying to breathe, and they're panicking because of that, okay? Now, in that condition, what is causing the brain to sense that air starvation? It's not hypoxia like you'd think, it's hypercapnia, all right? The main respiratory drive, remember, is high CO2. Now, the opioids, like morphine as your prototype, but it goes along with them, actually blunt the CO2 receptor response. In a bad case, that's how they kill. If you look at heroin overdoses, they're having big problems with opiate overdoses. All those people die from respiratory arrest, okay? One of the problems is that with opioids, people build a tolerance to the euphoric effects, but they don't build a tolerance to the respiratory depression. So they keep getting higher, having to take higher and higher doses to get the euphoria, and eventually they pass over the line into respiratory depression, and they go into a respiratory arrest and die. All right, well, we use smaller doses, non-toxic doses, for the benefit of the patient. And you can take these and give them a low dose of an opioid, and it's sometimes dramatic. These animals will go from a frantic fighting, trying to breathe, to they're calmer. It's a more relaxed, rhythmic respiration than the panting, fighting respiration they were going under. Part of that is the sedation from the opioid, but a bigger part is blunting that CO2 receptor. Now, in humans, they use morphine routinely for this. Morphine is more emetogenic in the dog, so we tend to use other opioids instead. A lot of times we use butorphanol simply because it's readily available and it has a low schedule in terms of being a controlled drug. But a lot of the others will do so as well. And then lastly, problems that we're trying to avoid, things to be aware of. Bronchospasm, I've already mentioned acetylcysteine. You'll notice the local anesthetic is crossed out. There was a product called Cetacane that was a local anesthetic, and it came in a little yellow bottle that was pressurized, and you could just kind of push the tip and it would spray out, kind of like WD-40, except it was a local anesthetic. And a lot of people would put those on the retinoids of animals, particularly cats, to make it easier to intubate. The problem was some of those would have a laryngospasm, and then you had that emergency to deal with. So it got to be said that you shouldn't do that. Well, kind of bottom line is that laryngospasm was probably from the vehicle, the aerosol propellant in the Cetacane. It is perfectly acceptable to take some lidocaine in a syringe and a long blunt needle and drop some lidocaine on the retinoids of a cat. That's fine, but you don't want to use the Cetacane. Again, cholinergic and anticholinesterase, which is the same thing basically in terms of effect, will cause bronchoconstriction. So the organophosphate insecticides, these sorts of things, and some of the muscarinic agonists have a low incidence where this can occur. Propranolol and aspirin are kind of interesting. This is well documented in humans. We presume it's written up relative to cats. We don't know for sure how often it occurs. But propranolol, remember, is a non-selective beta blocker. It blocks beta 1s and beta 2s. And part of the reason we use atenolol now is it's selective for beta 1. What occurs in a small subset of humans is by blocking the beta 2 in an asthmatic, you block their compensatory bronchodilation capabilities. So you can take an asthmatic and give them propranolol and cause an acute episode of asthma. So that's propranolol. Aspirin has been noted the same way. There are bronchodilatory prostaglandins that aspirin will inhibit the production of. So again, in humans, aspirin has caused acute bronchoconstrictive episodes in asthmatics. So as I said, it's written up relative to cats. We don't know how often it really occurs. I've never seen it. Also remember that your type 1 hypersensitivities, your allergic reactions may include bronchoconstriction. The milder form is just the puffiness, the swelling, the urticaria, or the GI signs, but the more severe forms will include bronchoconstriction. So there we may have to add something besides just an antihistamine, okay? Avoid drying. It's kind of self-explanatory. The anticholinergics, as I said, like atropine, are going to do that. So we don't use them if we can avoid it in respiratory disease. If we do use it, it's only for an emergency and we try to move on. Now, antihistamines I want to mention because remember, antihistamines really only have proven efficacy in allergic conditions. They don't really help in most infectious processes. Maybe in acute viral hypersecretory, where there's still thin, watery secretions, they might have a drying effect. But the bottom line is, in general, they do dry. Antihistamines have mild anticholinergic activity. That's why you get a dry mouth sometimes when you take Benadryl. Okay, so it's kind of a shame in a way that so many over-the-counter cold medicines have antihistamines in them. because once you're past that hypersecretory state, actually you're drying out those respiratory secretions. So antihistamines we largely avoid except for type 1 hypersensitivities. Pulmonary edema, don't use cisplatin in cats. Cisplat flats cats or splats cats. You'll hear that. So that's a species difference. And remember, in any heart failure and any oliguric renal failure, it's really easy to volume overload these animals. The heart failures particularly come in often with a very high volume from water and salt retention to start with. So you have to be extra careful with your fluid therapy not to volume overload these. And we'll talk about managing the oliguric renal failure in the next lecture. And lastly, potassium or sodium bromide is a good anticonvulsant in the dog, but we don't use it in cats because it has been associated with pneumonitis. Okay, I've actually seen it in dogs that were toxic, that were overdosed with bromide. They look a lot like an aspiration pneumonia in terms of how they behave and the respiratory signs, but it's not true aspiration. It's actually a chemical or a drug-induced pneumonitis that's been associated with bromide. All right, so I think that's the last slide. Any questions on anything? All right, then we'll go over urinary therapeutics tomorrow.